Good morning, everyone. Welcome to the community conversation on unlocking the future of fatty liver risk assessment. And we're really excited today to introduce the Fatty Liver Foundation's AI-driven tool with our partner from Array Insight. My name is Henry Chang. I'm the Executive Director of the Fatty Liver Foundation. Next slide, please. Next. So for those of you who are not familiar with the Fatty Liver Foundation, FLF is a nonprofit organization dedicated to improving the identification, diagnosis, treatment, and support people living with fatty liver, NAFLD, or NASH through awareness, screening, education, and patient outreach. We invite you to visit our website for more information. Next. Before we begin, just wanted to highlight the disclosure of unlabeled use statement, as well as the disclaimer. This session is by no means providing information on FDA-approved agents or diagnostics. I think all of you should also be aware that any procedures, medications, other courses of diagnosis, treatment discussed, or suggesting activity should not be used by patients without consultation with your medical providers as well as clinicians. Thanks. So what we're going to be doing today is to once again focus on the partnership that we developed with Array Insight on the web-based tool, which employs advanced machine learning algorithms to deliver real-time liver disease risk assessments. We hope that by the end of this session, you'll discover how this tool is set to transform the diagnosis and management of fatty liver disease. Next. I'll just walk you through our learning objectives for today. One is to understand how the FLF AI risk stratification tool can accurately assess the risk of fatty liver disease. Discover the innovative technology behind the tool, including machine learning models and federated data platforms that you will hear from our colleague from Array Insights. Learn how more inclusive and robust data sets will improve the tool's predictive power. And lastly, explore the impact of this tool in identifying at-risk individuals and improve healthcare outcomes. So with that, I will turn this over to Dr. Niraj Mistry, who's our Chief Medical Officer at the Fatty Liver Foundation, and he'll talk about bridging the gaps with technology, making liver disease a priority. Over to you, Niraj.
Thank you, Henry, and delighted to be talking through this. So a lot of us consider NASH to be this gathering storm. And this is mainly because NASH is a very subclinical, or NAFLD is a very subclinical disease. That is, it doesn't have any presentation for a long, long time. And so it develops silently in the body. And there's many reasons because of that. And mainly it's because the liver is a very resilient organ. It works very efficiently until it doesn't. And by then, it's quite late in the disease progression, and that's when people present with symptoms. And so we feel that this is a gathering storm because we don't have the infrastructure and the systems in place to actually screen for and pick up early people who may be at risk of or in the early stages of NAFLD and NASH. And that's the challenge that we face. Now, the problem then that results from that is that by the time that patients present, the disease is so advanced that it requires advanced medical management, which includes things like liver transplants, long periods of hospitalization, lots of medication after that. And that exacts a huge cost on the health system. So with the adage of an ounce of prevention is better than a pound of cure, our whole notion is, can we find these cases much earlier? Now, looking at the traditional ways of screening with the tests, biomarkers, scans, etc., and ultimately liver biopsy, we felt that using AI was the opportunity where we could find the combination of these risk factors that pointed us to those people that may be on a trajectory to develop this disease. Next slide, please. Thank you. So when we look at what these risk factors are and causes of NASH, and NAFLD or this fatty liver, Well, we know that there's a genetic association with it, and genetic associations don't necessarily mean that a person will for 100% develop the disease. Our understanding is clearly now that those with a genetic predisposition will sort of move down a path when they have those environmental stimuli that cause them to develop the disease. Obesity is a very strong association. That together with type 2 diabetes, fatty liver can result as a side effect of medications, as well as the fats in the blood like high cholesterol and triglycerides. And also with some patients, we see that rapid weight loss, particularly with the lean type of NASH, can predispose to this. Now, these look like a lot of factors, and some people have an overlap of 2, 3, 4, 5 factors sometimes. And so what we need to then understand is what is the weighting of each of these factors and what is the combination of factors that actually would point to a person's particular risk. Okay. Just a bit of 101, on the left-hand side, we have a normal healthy liver. And then with the risk factors like obesity, among others, we find that there's an increase in the blood concentration of these fats, which are then stored in the liver, cause this sort of irritation in the liver that leads to the inflammation and over time, fibrosis and cirrhosis. So that's NASH in a nutshell. NAFLD and NASH is also a combination of, or a confluence of many comorbidities. And by comorbidities, we mean other conditions that a person has at the same time. And what's also really interesting is that it's a chicken and hen story with some of these things, or a chicken and egg story, where they can lead to the condition, but the condition also exacerbates those underlying comorbidities. And so we need to understand how all these factors play together. Next slide, please. And from a public health point of view, I think this is also very interesting. When we look at the well-being of a patient or any individual, the contributing factors are those individual behaviors, which are the vast majority of it, the 40%, which includes alcohol consumption, exercise, lifestyle factors, smoking, as well as, very important with fatty liver disease, diet, what we eat, how we eat, and how much of it we eat. So that contributes to an individual's health and well-being. Together with the social and environmental context, those lifestyle factors like work stress, sedentary lifestyles, etc., genetics, and we talked about that interaction with the environment, and the availability of healthcare services is just a small proportion in terms of contributing to a person's well-being. And so as a patient advocacy organization, we work very closely to modify those lifestyle and environmental factors that is critical to prevention. Next slide. Okay, so one of the big challenges we have is that getting people screened and tested to assess their risk becomes much, much harder when people live busy lifestyles and don't have access to health facilities. And this is where we have the opportunity with this tool, which we're really excited with this collaboration to start exploring much further. And we want to make sure that patients are aware of opportunities like this so that they can work with their doctors. We firmly believe in the co-management of a patient's condition with the healthcare system and their engagement. So if we have tools like this, we can make a difference in that sort of way. Next slide, please. And so we really looking to this partnership to bridge the use of this technology, big data world that we live in, and make it really, really meaningful and impactful for patients to pick them up early and sort of avoid them going down this trajectory of the disease. So with that, let me hand over to our new partner, collaborator, and family and friend of the Fatty Liver Foundation, and over to you.
Thanks, Uniraj. Hi, my name is Ann Kim. I am the co-founder and CEO of Array Insights. And so I'll be telling you about our risk stratification partnership with the Fatty Liver Foundation based on some work that I did at MIT. My background is in computer science and molecular biology. And so in that graduate work, I did a lot of privacy preserving machine learning because we saw that as a pretty big bottleneck for being able to get better representation and more subtle idiosyncrasies about the cause of disease and the risk for disease. Next slide, please. And so what we do is we work with patient-focused organizations, patient advocacy organizations, for being able to provide software that allows them to securely and ethically source data, analyze it, and then create tools for things that matter to patients, such as earlier diagnosis or better recommendations for treatment of care with other partners. So we're really excited about this collaboration. We're excited to be here at the liver meeting. We're all in the same room here, and it's very, very exciting to see other opportunities for being able to listen to patients en masse and then being able to distill it with the aid of AI. Next slide, please. And so one of the biggest challenges for AI is data and the patients who are contributing that data and trust the stewardship of their doctors as well as patient organizations for this. And so, we're all familiar with racial disparities as well as different types of disadvantages for different groups based on histories. And so the big challenge is having representation and being able to improve care and diversity while also respecting the trust of these patients. Oftentimes, even in anonymized patient records, you're not actually getting provenance as well as consent from these patients for being able to do this sort of work. And so it's important for us to be partnering with organizations like the Fatty Liver Foundation who are lockstep with patients. Next slide, please. And so what we use for doing this type of analysis is something you've probably already heard about, machine learning. And so what is it at a high level is that we're able to take data, and all this data has different types of relationships between them. We've heard from Niraj that there's a lot of associations with comorbidities at different gradations. Maybe if you have a really high BMI, then it has a really high impact on your risk for fatty liver. If you have slightly overweight BMI, that might have a lower risk impact. And so these are subtleties that as a human or as a physician, you might be able to understand from a qualitative perspective, but from a quantitative perspective, I can't just calculate, oh, this is your risk based on, my assessment of looking at your charts. It's much too much information for one individual or many people to even distill. And so we use the tool of machine learning to create these models that are then quantifying a lot of these relationships across many different factors and then labeling that based on tests of patients who have fatty liver or do not have fatty liver and at what sort of severity. Next slide, please. And so on the left or the right, you can see that there's this mountain, right? And so this is an abstraction for something called a gradient. And across all these different factors, whether it's gender or age or BMI or diet, this is an abstraction for being able to say what is kind of the optimal consideration of these different factors. And so doing gradient descent across this, you're able to find these local or hopefully global minimas for being able to optimize this objective of getting better prediction for risk factors. And so that's kind of what you're looking at. So if you can imagine, you are somewhere on this gradient, you have a lot of information across many different patients, and then you're just trying to find a pattern there that then minimizes the error for that model to predict what your risk percent is. Next slide, please. And so there are a lot of different opportunities here for the application of AI. I'm sure you've read several articles about it in not only drug discovery, but all the way up to patient care and even better practices for detecting disease prior to diagnosis. And so it's extremely exciting to see what these outcomes can look like. And it's also really exciting to also see the sources of these data sets. So we're really talking about the Sun data set, but I also want to share some more information about opportunities to lower that barrier to access for representation of patients based on just patient history or patient stories. Next slide, please. So I mentioned before that a lot of my research was in privacy and security at MIT. And so a lot of what we found was these data sets that are extremely important for the prediction of health outcomes is going to be in various different centers, whether it's because you have, as a patient, moved around the country, or because you're going to one clinic but being diagnosed somewhere else and getting treatment at another clinic. These data sets are very siloed. In fact, earlier today, we talked about silos in just health in general, that a lot of liver diseases or comorbidities are siloed information. And so by being able to have something like federated learning or federated architecture, you're able to link all of these factors without compromising privacy, which is of utmost importance for patients. Next slide. And so what we're able to do is we're able to work with many different types of data sets. And unlike other data brokers, what we are doing is using privacy preserving techniques to enhance these predictive measures and risk stratifications without necessarily having the risk of inherent to data sharing and pooling data in one place. Next slide. So I'll go into the details of what we actually did with the Fatty Liver Foundation and risk stratification tool. So what we called our system was the Patient Decision Aid System, or PDAS. And so what we were trying to do is we use the SUN dataset, which has almost 1,000 patients in it, based on BMI and basic information about these patients and like diet. They, over a pretty significant period of time, gave this type of survey information that was very significant for having this type of like risk stratification tool and training that tool. And so we use many different methods, and the one that we ended up using and getting the best results out of was XGBoost. Next slide, please. So what we were able to do was by using this data set, training this XGBoost algorithm, we were able to then have different types of like easy to interpret kind of risks for the contribution of these different types of factors for the ultimate risk of fatty liver. So what we were able to do is then after we had these curves of like correlation, we used the area under the curve in order to have an idea of what the optimization was or what the performance of this model was. Next slide. So this process, we found that we had a pretty significant detection rate, 77% for NAFLD. And what we were able to do is, what we want to do in the future is enhance this model and improve this. And so we're hoping to launch this in early 2024 for being able to do risk stratification based on these types of data sets. But ultimately, what's also really exciting is that it doesn't stop with just SUN1 data or any sort of survey data. You've probably heard about ChatGPT or other large language models. There's a lot of opportunity for being able to incorporate all the different richness of a patient journey for different risk prediction. So we're really excited about the start of this work and really excited about the future as well. Next slide. So if you're here at the liver meeting, you should catch our poster 2002A. And Niraj, Henry, do we have anything else that we want to share?
And thanks so much. We have some time, so we're going to open the Q&A and chat box for questions, but I want to kick off with a couple of questions. And, you know, in the liver world, we're now moving from this whole sort of let's do a biopsy and advanced biomedical test to what we're saying are called non-invasive tests. And what's exciting about this is we're not just looking at biomarkers, but we're looking at the lifestyle, social, and environmental conditions that can help predict risk. And the opportunity we then have to actually go to incorporating that with biomedical data, you know, would take things to another level. But I think one of the really important things about this federated data model, if I got that right, is that it protects patients, right? In that the data remains confidential, right? Can you tell us a bit more about that? Because I think when it comes to big data, one of the big concerns is confidentiality.
So inherent to any sort of machine learning practice, it starts with data. And so if this data comes from many different sources, typically I'll put them into one resource and do analysis on that as a computer scientist. So I might peek at the data, or I have all the data in one place where I needed to get IRB approval or data use agreements across all these different institutions to share, and then have that intrinsically like in one potential vulnerability. And so instead, what federated learning does is that the data stays like remote to all these different sites, and then the computation happens at that site. So you don't necessarily have to have that vulnerability of putting all the data in one place. Additionally, in different federated workflows, what you can do is you also mitigate the risk of the researcher themselves like seeing the data by having different tools of like doing this type of remote computation, and then having the results of that computation combined instead of the data itself.
So that's really helpful. And I got to appreciate the fact that you're making this complex technology stuff quite accessible for people like myself, and I hope many of our listeners as well. The next question links to how do we ensure that the data set used to generate the model is sufficiently diverse? And I think that's really, really important, because we know our patient group is not a homogeneous group, and there's a lot of diversity within it. Yeah. So let's take the one with the diversity, and then we'll come back to the other one with the AI tool. Right. And so we want to look at generalizability, but at the same time, we want to ensure that we retain the nuance and the specificity, right?
Yeah. I mean, that goes beyond just the machine learning aspect. It's like going to the aspect of patient advocacy and education and accessibility to get to those patients. So a subtlety about the Sun1 data set is that it also involved liver biopsy in order to check against what you are recording from a lifestyle perspective to see, okay, what is the sort of degradation of the liver? I forget what the clinical term is, right? But it means that intrinsically these patients have to be close to a center where they can do that biopsy, which means that if you live in a remote area, or if you're not aware of where that can happen, that means those patients are represented. And oftentimes those are patients that have like, who live in areas of like low Gini scores, or don't have that sort of accessibility, and oftentimes people of color, or have like economic challenges ahead of them, right? To even participate and like put that time into a study. And so I think what's really exciting about newer technologies in AI is that a lot of it can be done remotely. We're hearing a lot about remote clinical trials, and I think a lot of that workflow is not an AI, it's literally having the sponsorship to get a device mailed to a patient, and then having that device mailed back, and then having reusability such that this economically makes sense for that type of study. Or similarly, if you're thinking about this type of data, like perhaps a lot of the survey information could have been done like remotely. I don't know how you do a remote liver biopsy, but perhaps there's a startup out there that is actually like cryogenically freezing these liver biopsies and then sending them back to a lab.
It's all starting to get very, very advanced. So I wouldn't say anything is off the agenda. But I think related to that is to the question, and to build on what you said, it's not a single equation that's going to result in our risk stratification. And so the categories of risk that would emerge would be a combination of various algorithms, right? And they may have, so two patients may go with their data entered, will have the same risk, but they have different risk factors, and they weight it differently, right? And I think that captures the diversity within the populations that we're dealing with. And obviously, then with very unique groups within our patient population, we'll need more data and more patient experience. So I think we have a way of incorporating both in this risk stratification tool. There's another question that's
about XGBoost.
A bit technical for me. It's fascinating methodology. I'm curious about what and how many features you use for your XGBT AI tool.
Yeah, how many features do we use, Adam, for the XGBoost model? Between 8 and 12. I see. Yeah. Why did we remove the 32? Okay. Yeah.
And would you explain to our group what this XGBT AI tool is?
Yeah, I mean, it's a type of like decision tree model, right? And it has like high interpretability of like what these different factors are. It's not necessarily like just linear, I think, but what it does is like, to Adam's point, we started with 50 features. So the Sun1 data set has, say, like 50 questions about a patient, and in answering them, we try to do prediction based on that. And what XGBoost did was, it was clear that around 40 of those factors did not necessarily have like high prediction for NAFLD NASH. So instead, we narrowed it down to like 8 or 12 that were more predictive, and I guess had like a better Shapley value, right?
So there's a follow-up question on what those features were that were used, and that's included in our poster, right? So what we will do is we'll make the poster available to all our callers, and we'll post it on our website and our various channels. So, and I do have a question as well. Given you on the technology side and we're on the patient biomedical side, I want to ask you, what would your wish be for this AI and how we expand with this?
I mean, I think people ask some really good questions about explainability, as well as diversity and accessibility, which are major questions in machine learning right now. From a general perspective, people want to better understand these models, why they're making these predictions, because they're important for the human in the loop aspect of any of these models in terms of implementation for actual impact for people. And another piece of it is being able to have more diverse representation. Another piece of sort of like general machine learning and like large questions there. And so my wish would be to have larger representation through like lower accessibility points. So I think you see this in a lot of health initiatives across the world, that like once you reduce accessibility, once you bring doctors to patients, once you are able to do clinical trials at home, you're able to drastically improve representation because it makes it easier and overcomes perhaps some of the challenges about systemic reasons for why we don't have this type of representation. So my wish would be that like education as well as accessibility of these models or sponsorship of these types of tools to the patient would increase. Because I think we'll see a lot of really amazing benefits for all patients at large for having this type of predictability. And I could go on for hours, I think, about what the benefits are of having like diversity and representation for all patients, not just like the patients that you're including, but patients that were already included but are missing idiosyncrasies about health.
I'm going to build on that with my wish from the biomedical side and the patient behavior side. And one of the things we've seen is that health-seeking behavior is a tough one to actually instill in people. And it's not just a simple question about education and spread awareness, and then people will change their behavior. And I do think that if we can develop this risk stratification tool, which is a broader lifestyle issue when we look at all the comorbidities, and this is something that a patient can do themselves, it's at home based, then that would then induce them to take responsibility for health, to sort of put them on a path of health-seeking behavior, and then maybe also start that trajectory of behavior change with the fact that they almost self-diagnose their risk profile and can take sort of matters into their hands at an early stage of prevention rather than wait for the disease to progress. So a really exciting collaboration, and thank you for your time. I hope you're enjoying the conference, and we will make this webinar available. It's been recorded, as well as share the information about the poster that's being presented here. So thank you all once again for attending, and we look forward to staying in touch.
Yeah, thank you so much. And again, I really love that we were able to offer this as a webinar format because it, speaks to what we're talking about in terms of accessibility for getting this type of information without having to get a plane ride and like a hotel room in Boston, right? Like they're able to just find this on the website. So that's awesome. We love working with the Fatty Liver Foundation for that exact reason.
Thank you, and take care, everyone.
Thank you. Bye.
Bye.